This is Jonathon Feit, co-founder and CEO of Beyond Lucid Technologies and a consultant with the brain trust of Fire and EMS technologists. Thanks for joining me today for a conversation about how mobile medical agencies in the field partner and interoperate across their healthcare ecosystems. In order to purposefully and constructively participate at the table of the future of healthcare, mobile medical professionals need to be able to share their insights and the work that they have done to help an elderly patient who fell on the floor stand tall and confident again, to keeping those who have been afflicted by COVID-19 alive until the virus can pass out of their bodies, to dealing with patients who are putting harmful substances in their bodies that didn't belong there and to which they've become addicted, and to ripping patients out of burning buildings and cars and making sure that they live to see their families again. Within the mobile medical technology business, I have developed something of a reputation, not as a clinician, because I'm not one, but rather as a technologist, a data geek, and a business person. I'm chief executive of the only technology firm in our industry that was founded by two non-clinician MBAs. And once upon a time, still today, even after over a decade, I get challenged with the question, basically, what do I know? Because I've never formally served in the back of an ambulance or on a fire engine. That's true. Although I did get into this business because I joined the United States Army Reserve, a little known fact, on September 11th, 2001. I had been planning and hoping to become a field medic. My MOS was 91 Whiskey, for anyone who knows the military occupational specialty numbers. But unfortunately, Tourette syndrome and the United States military are not comfortable bedfellows. That's probably a story for another time. The fact is, many of the challenges that mobile medical professionals deal with on a daily basis can be addressed in multiple ways. In fact, that is arguably one of the hallmarks of an art like medicine, that there isn't a right way or a wrong way to do things. There is an approved way, there is a risky way, there are algorithms, and there are protocols. Those latter two are particularly designed to lend some science to the art, to determine best practices, and to hopefully replicate what works, while occasionally still leaving room for things to be modified or challenged when the train falls off the tracks. Even the algorithms and protocols, that is to say, need to be bent from time to time. For example, as I record this, just yesterday, the United States Food and Drug Administration approved the use of the first medication to treat COVID-19 under emergency use. The drug wasn't originally designed for this novel coronavirus, quote unquote. After all, something that's novel requires novel thinking. But the rule was bent because it is hoped that the end will justify the means. Data standards, by contrast, are different. They exist precisely to avoid art. They seek to avoid the flexibility that comes with art and its openness to opinion. One might say that their objective is to, in fact, create the objective. That is, to take personal preference out of the equation, so that there is just a handful of ways to get the goal accomplished. Usually there does need to be more than one way to do things because circumstances matter. Say, for example, a piece of software is being run on a computer that's so old that backwards compatibility with previous operating systems is required. You don't necessarily want to have to go backwards forever because that would be a nightmare to support over time. So you pick a duration and go back, say, 2 generations of software, 2 model years, that sort of thing. The purpose of standards is to allow systems to operate by the same sets of rules, on the same playing field, if you will, and therefore to know that a goal can be accomplished basically no matter what. It is the opposite of custom development. And while custom development is generally guaranteed to accomplish the desired task, it is definitely not guaranteed to be resilient to change. In fact, usually the opposite is true. What is custom tends to break. It's inherently fragile, and it can be far harder to repair, restore, or replace. Forget computer software or health IT for a moment. Think of cars instead. Do you think it's easier to get a Ford, Chevy, or Toyota fixed when something breaks, or a one-off supercar manufactured like a legendary piece of art? The latter is couture. It may be beautiful, expensive, desirable. Its demand and is tied to scarcity, and perhaps its value even goes up over time. But at the same time, it is also far more likely to end up sitting in your driveway, unable to move. Or you'll have to pay the artist that created it accordingly to come out and fix your specially designed taillight. In healthcare information technology, the federal government did away with couture technology. That's kind of the perfect word for actually what it was trying to get away from. According to the Office of the National Coordinator of Health IT, in fact, in 2004, President Bush issued an executive order, specifically Executive Order number 13335, forming the Office of the National Coordinator of Healthcare Information Technology, which has since become known simply as the Office of the National Coordinator, or ONC, as one of its executives recently informed me, quote, to provide leadership for the development and nationwide implementation of an interoperable health information technology infrastructure to improve the quality and efficiency of healthcare, end quote. But we really started cooking with gas, as the saying goes, in 2009, when, according to the Centers for Disease Control and Prevention, quote, one of the stated goals of the American Reinvestment and Recovery Act, by the way, more commonly known as the Stimulus Act, enacted by President Barack Obama, is to increase the meaningful use of electronic health record systems among medical providers, end quote. The so-called meaningful use standard, sometimes abbreviated as MU in the literature and in guidance documents, sets out a series of rules and standards, compliance with which can be certified by the federal government. And there was an incentive program for electronic health record companies to meet these standards. If the software developers met the standards and provided the benefits set forth under the MU framework, clinicians would actually be paid to use them. These so-called incentive payments were the growth hormone that really exploded companies like Epic, Cerner, Meditech, and Athena Health. But mobile medicine providers didn't have access to these incentives because meaningful use, a product of the Office of the National Coordinator of Health IT, or ONC, applies to clinical practices housed under the purview of the United States Department of Health and Human Services. Mobile medicine doesn't sit there. Our industry sits in the Department of Transportation for reasons that go back many moons and are beyond the scope of this discussion today. On the one hand, a lack of meaningful use requirements makes it easier for software developers because MU is a strong framework that puts a burden on technology. On the other hand, the purpose of the MU framework is to ensure that software is just that, meaningful. And mobile medicine lacks any such controls. But it gets worse. As I pointed out in an article for Becker's Hospital Review from a lifetime ago in 2016, titled, quote, Different Colors of Money, Federal Funding Silos Have Hamstrung the EMS to Hospital Data Continuum, How to Correct the Disjoint, end quote. There is a conflict between the standards coming down from the two federal offices because the reporting incentives of the two offices are misaligned. Being inside the Department of Transportation, the National Highway Traffic Safety Administration, which oversees the National EMS Information System, is oriented by provenance toward logistics, vehicles moving around. By contrast, the data coming out of HHS, and specifically ONC, is oriented toward patient care. The problem Although problem is probably a strong word for it because mobile medical providers do sacred work and do a wonderful job of it in general. But from a technical standpoint, I suppose, the problem is mobile medicine, a broad and overarching name for emergency medical services and medical transportation based in all sorts of organizations, from public ambulance services to private medical transportation and ambulance companies, hospital-affiliated entities that touch the emergency department, to fire departments and special fire protection districts, and most recently, community paramedicine or mobile integrated health programs that are as varied as the many facets of a diamond do both. They provide patient care and they move around. They usually operate at the patient's side, in the field, under bridges, in basements, outside, basically, of an office setting, which is where the meaningful use-oriented electronic health records were designed to operate. Therefore, we run into a problem, a conflict, or, depending on your feelings on the matter, like mine, a slow-moving train wreck. And this was actually foreshadowed, perhaps ironically, in the classic 1997 Jodie Foster movie, Contact. Namely, what is the first rule of government contracting? Answer: why build one when you can have two at twice the price? So let's talk about those standards in a bit of gory detail. The National EMS Information System, or NEMSIS, version 2 had roughly 250 data points. The new version, version 3, which went into effect as the de facto standard in 2013, has over 500 data points, so it's more than twice as complex. A new iteration, version 3.5, is currently in the works. The problem is that neither of these dot versions, neither NEMSIS version 2 nor version 3, actually interoperates directly with the structure of the electronic health records on the hospital side. And by hospital side, I also mean health information exchanges, doctors' offices, nursing facilities, pharmacies, etc. Those more traditional healthcare record systems use a standard based on Health Level 7, more commonly called HL7, as its backbone. HL7 and NEMSIS are to one another what Mac OS is to Windows, or iOS is to Android, or AC is to DC. Each exists in its own sphere, each has its purpose, and they're separate but not quite equal. Parts that overlap, but they don't fit quite well. Theoretically, it should be possible to turn a circle into a square to fit one into the other's holes, but the technical mechanisms to do so were never made clear. So each side of the patient care handoff, the crew bringing a sorry soul to the emergency department, and the folks on the receiving side trying to figure out what to do next, have languished without interoperability despite the need to share data for many moons. Then, in June 2014, a collaboration comprised of the state of California's EMS Authority, American Medical Response, the largest U.S. ambulance company, which at that time had a contract with Contra Costa County, California, and a health information exchange that no longer exists, contacted my tiny, sprightly team of misfits about a desire to share ambulance information with Kaiser Permanente's electronic health record system, which is made by a large and globally known company called Epic. Epic, for its part, states right on its website that, quote, Epic's EHR can consume any valid CCDA or CDA document, period. No qualifiers. It can accept them. It is what it is. It's pretty plain. And then the website goes on to explain how to give it the records. Meaningful use includes provisions regarding standards for data sharing using HL7. And those provisions focus on a basket of variants known collectively as the Clinical Document Architecture, or CDA, that the Epic language was referring to. The CDA comprises several different types of documents that serve slightly different purposes, and each version has its pro and con in terms of flexibility, the ability to carry along attachments, etc. But as long as a document is fundamentally a CDA, one of the federally recognized types, Epic and other meaningful use certified EHRs should be able to consume the document and extract its data. By the way, the CCDA stands for the Consolidated Clinical Document Architecture, a more modern version of the CDA that is nevertheless part of the same suite of HL7-based solutions. Now, according to the Health Information Exchange's president and CTO had come to my team about helping to affect interoperability in Contra Costa County, quote, KP, that is Kaiser Permanente, wanted to receive a standard CDA based on the HL7 approved CDA format. But AMR, American Medical Response, that large ambulance service, presently only supports version 2.2, end quote. Now, although AMR is now on version 3, that ultimately wouldn't matter, as we're going to discuss in a second. The state of California, this HIE executive told me, was, quote, very skeptical that a competent conversion could be established to move data into the approved CDA format coming from a V2.2 database, end quote. Why is that? Why should it be so difficult to translate the EMS data set into a consumable document on the receiving hospital side? Now, it turns out, when handing data from the pre-hospital arena to the in-hospital arena, important holes result due to the separate nature of each data set's origin. And ultimately, what we're going to talk about in the next few minutes here is what happens when trying to give back data after the hospital visit. So, in other words, you've got data coming into the hospital that has holes in the data set that need to be filled, and then you need to try to give back a fuller, more robust document into a smaller hose, which has holes in different places. So basically, what you're trying to do is give back data afterwards so that EMS can close the loop on what happened to its patient and what needs to happen next, because so often when the patient leaves the hospital, they ultimately will end up coming back to the hospital again using another ambulance trip. Unfortunately, closing the loop in that way is virtually impossible using the standardized methods that are in the federal basket of documents recognized through most of the care continuum, except for EMS and fire, which exist under the NEMSIS framework. So remember, meaningful use tied to HL7, tied to the CDA, and the CDA, by the way, is an HL7 version 3 construct. Anything HL7 version 2 predates the clinical document architecture. What all of this technical detail is to say is that any person in the fire or EMS technology world who says that their company can simply return data back from an EHR through a standard non-custom interface that is also meaningful use compliant is quite simply full of crap. It's not possible. We're getting there, but the new necessary standards to rip apart the federally standardized documents and share them piecemeal doesn't even become a rule of the road, so to speak, until 2022, in accordance with the 21st Century Cures Act. A set of rules in and of itself phases in over time. So let's get back to the question. The state of California EMS Authority, this large ambulance service, and a Health Information Exchange want to share data with Kaiser Permanente's Epic EHR. They come to my organization to ask how to do it and why is it so difficult. By my estimation, after completing a gap analysis of the NEMSIS mobile medical documentation system, what existed in the ambulance, what exists in a fire vehicle that's doing medical care, and on the receiving side in the hospital, in the nursing facility, in the pharmacy, in the doctor's office, in the clinic. That's the HL7 structured system. And that investigation, by the way, the gap analysis was funded by the California Healthcare Foundation. So grateful to them, of course. I estimate to be around 85%. Pretty substantial overlap because, after all, how many different ways are there to capture names and insurance numbers and blood pressures and whether or not you're taking Tylenol or morphine or you have asthma, right? I mean, there's only so many ways that you can describe those different clinical details that exist, whether you're in an ambulance or you're in an emergency department. But the question and the interesting thing was, what's in those estimated 15%? What is it that needed to be appended to the NEMSIS record in order to make it consumable on the hospital side? And that's where things got really interesting. In that 15%, we found that it basically 3 buckets. So mental health, past encounters, and family history. Again, mental health, past encounters, and family history. This is relevant because it looks at the expansion of healthcare that we're dealing with right now, focused on knowing who patients are when you go out to take care of them. How can you address patients' concerns that exist over time to preempt their need for emergency department visits? How can you have some sense of what might be wrong with them because you understand the clinical context that they came from, because their father was a diabetic and their mother had some other disease that may have passed down genetically, or that they came from a broken home, and so adverse childhood experiences have a known impact on mental health and wellness, and so on and so forth. So by looking at these longitudinal elements, which come into current models of the expansion of care, such as the new ET3 program under the Center for Medicare and Medicaid Innovation, if you add those data elements onto the 911 record that exists inside this Nemesis architecture, it turns out you get something consumable. You have to package it right. But nevertheless, what we were able to do once we identified those gaps and defined and identified the standard of that structure under the meaningful use framework, we were able to back build a conversion engine that would append the missing data elements onto the Nemesis file and restructure it into an HL7 document that could be run through a CDA validator, a clinical document architecture validator, using, in our case, the subtype known as the CCD, which stands for Continuity of Care Document. This Continuity of Care Document, the CCD, happens to be one of the oldest of the standard interoperable forms, and although it's not especially flexible in its construction, its age with respect to meaningful use happened to be advantageous to us because it is among the most widely accepted CDA subtypes. And nevertheless, it is still consumable by the meaningful use certified EHRs and HIEs. The reason for this is that not all EHRs update themselves at the same frequency, right? Electronic health records like Epic and Cerner are very expensive. And even doctor office or small practice oriented EHRs like Dr. Chrono and Athena Health can still take substantial work to change in terms of the software and updating it to new standards, and also then from the personnel perspective in terms of training on new systems. So lots of EHR vendors tend to stay relatively static over long periods of time. And in some cases, institutions like the Indian health system basically hasn't updated its electronic health record system in a decade or so. So as long as you are compliant with the earliest of the CDA structures under the meaningful use framework, you can still share data with them. And so that's a very powerful advantage in terms of being able to serve the healthcare community at large, because no matter where you go, as long as the receiving side can handle the standard, you can send them mobile medical data that can be consumed into the electronic health record. The problem is, and this is where things have hit on the rocks of reality or run over the spikes in the parking lot, if you want to use that analogy, in places like California, is that sometimes when you reinvent the wheel, you reinvent it crooked, right? And that happened. When the National EMS Information System Technical Assistance Center, or the Nemesis TAC for short, posted on its website a document called the CDA-R2, or Clinical Document Architecture Release 2, Implementation Guide for EMS. And this was back around 2015. That document, the CDA-R2 Implementation Guide, supposedly designed for EMS, unfortunately, that document featured a variety of wicked errors that basically resulted in garbage. So we talk about the GIGO problem, or garbage in, garbage out problem. Here was a perfect example of, if you didn't know where all the Easter eggs were in the implementation guide, you basically built yourself a steaming pile of nothing that would work. The error was specific. Some of the key translational codes known as LOINC, or logical observation identifiers, names and codes, were mismatched. You mismatch those codes, your documents go nowhere. So we brought this fatal error to the attention of the organization that oversees the LOINC codes. That is the Regenstrief Institute at the University of Indiana, in September 2015. And this is what they said, quote, "Thanks for apprising us of these issues. I am forwarding your message to the person who heads our LOINC program. He will be happy to help resolve these issues," end quote. To our knowledge, they never did. And yet, we haven't found them, but companies seem to keep relying on that document. And then they wondered why the data that were supplied using a, quote, HL7 for EMS, end quote, construct refused to flow. EHR manufacturers are starting to notice. In March of 2020, so now we're talking about 5 years after we pointed out the errors in the CDA-R2 for EMS to convert Nemesis to HL7, one of the largest health IT companies in the world, one of the largest electronic health record manufacturers in the world, has said that one of the largest EMS documentation systems, which has convinced hospital and public health and regional clients all over the country that it can share data bidirectionally, unfortunately, quote, doesn't yet support our normal kind of CDAs, and it's not on their development roadmap, end quote. So in other words, we meet the standard, except we don't. We can share data, except we can't. And when challenged as to how and when you're going to get with what you've promised, the answer is, we won't be getting there anytime soon. Whoops. That's going to be a problem. But all is not lost. With COVID-19 in the back of our minds, let's end on a positive note, because I'm one of those folks who post pictures of my kids on Instagram and Facebook with the hashtag quarantine silver lining. After all, if I'm not on the road, and though I love being on the road, in a plane, meeting users where they are and learning how my team can innovate to make their lives better and their jobs safer, if I have to be grounded, shall we say, then at least I get to enjoy more time with my kids. Hashtag quarantine silver lining. So I've been quasi-plagiarizing people far smarter than I am when I've called COVID a catalyst. For a number of months now, people have been pointing out that in healthcare technology especially, from telemedicine and remote monitoring to the computational biology and genetic engineering being used to build vaccines at frankly whiplashing speed, COVID has shaved off maybe a decade or more of what would otherwise have been gradual adoption, maybe kicking and screaming by the rest of the healthcare ecosystem. Likewise, when it's come to interoperability with other parts of the continuum. COVID-19 has given hospitals a reason to need to connect with mobile medical agencies in a way that they simply haven't realized before. They've needed to, but they just didn't realize it. Consider facilities like Kaiser Permanente, which are obsessed with efficiency. And yet, throughout California, going back to what we talked about, in 2014, there were moves afoot to try to get EMS data into Kaiser Permanente's emergency departments, and still they're entirely paper-based across California. Some of the largest hospitals in the country are still calling right now by phone every transport agency that has delivered a patient who ultimately got a COVID-19 test in order to provide the results over the phone. But some of the smallest hospitals are doing the same thing. And unlike those big hospitals, they don't have the ability to hire extra hands. So we have been seeing hospitals' bullshit meters fly off the charts. No longer can they suffer bobbing heads of salespeople simply saying, sure, we can do that. Instead, those facilities, the ecosystems in which they work, the public health services that they partner with, and the mobile medical agencies, Fire EMS, community paramedicine, and otherwise that are transporting those patients are demanding accountability for promises that technologists are making. And they are on the hunt for solutions that actually work. The hospitals need to know who is coming in the door so that they can better prepare. And mobile medical professionals need to be able to give them information that they're asking for, because this is their moment. For better or worse, when mobile medical providers are on the cover of Time magazine and on NBC Nightly News over and over again, and are finally receiving kudos for what they have done all along, but now they're doing it in front of the world, and so obviously putting themselves at risk in the process, healthcare leaders across the United States are saying, maybe you folks know things that we need to know. And that means, and this is exciting to me, that technology that's been waiting, it's been working, but from a productivity perspective, it's been largely waiting in the shadows for so long, is finally going to have a moment to shine. Thank you so very much for your interest in mobile medical interoperability with the rest of the healthcare system. Please don't hesitate to reach out if I can answer any questions, and thank you for all you do.